Hello, my name is Jill Attaman. I am a reproductive endocrinology and infertility specialist at Boston IVF. It's a pleasure to have you all here tonight. Thank you so much for joining. Maybe a little bit about myself, and then we'll jump into the Q&A that we have planned for this evening. You can call me Dr. A if you prefer. In fact, my parents were both school teachers, and they went by Mr. and Mrs. A respectively. So I have a nice connection with the Dr. A component. So please feel free. I have been practicing in New England since a fellowship that started in 2008 for me. So I'm starting to feel a bit older as time goes by. And I am committed to family building, helping all individuals try to accomplish their goals. I think because my parents were teachers, I have a strong focus in education. I have been working with the Guy's School of Medicine as well as Harvard Medical School for over 10 years at this point. And I love that portion of my job, but the most joy that I find is really in helping individuals build their families, welcoming a new little one to the world, saying hello to a parent for the first time, or seeing a family grow. With that, we'll treat everybody with kindness and respect because those are my core values, and I'm happy to get started. So thank you for listening. We did have a couple of questions that came in prior to starting, and I thought that one of them in particular would be fantastic to start with. And then I'll do my best to get through the Q&A. So the first question that I had come in was, can you talk a little bit about what to expect if just referred to Boston IVF by a nurse? Thank you. Well, you're welcome. Yes, I can talk about that because that is what I do on a day-to-day basis. So generally what will happen is you'll call for an appointment. There's an intake form that if you're able to complete online, you can complete. These questions will talk a lot about your history and who you are as a person. They're individualized to you. They're form questions, but we want to hear from you and what makes this a unique process for you and for a partner if you're coming in partnered for an evaluation. The intake will ask about history, your medical history. If menstrual histories are applicable to you, that will also be on the form. Partner history if you're partnered, and then an insurance check generally happens because a lot of folks will have some type of questions about the finances of an evaluation or what treatments may look like. So we generally have a very short insurance evaluation, so you have a general sense as to what to expect during the consultation. Then you come on in. You can either come in person or we can meet on Zoom. Options are available in many of our Boston IVF locations so that you can see a provider. And really that's where my primary goal at that initial consult is to establish what your goals are and to help you meet those goals. So that may be one of the first questions that I ask is what your goals are and what your family building goals are. And then we go from there. You will have an opportunity to ask questions during that appointment. Generally, we discuss whether there are any things that we can identify that might be helpful to you in what you're accomplishing, whether there are any lifestyle modifications, anything that I get a sense for that maybe could help optimize your success of an unassisted pregnancy. And then we discuss the plan, what testing you'd like to have for a plan. And one of the nurses will be kind enough to review it with you in further detail. And you leave the office or you have an email that comes to you with everything written out because it's a lot of information. We want to make sure that you know and feel comfortable with what's happening next. That's generally followed by another visit where we talk about results. There's a lot that happens in between that time, depending on what you're working on, but that may be testing of ovaries or sperm or the uterus, genetic screening. There's some testing that will happen pending where you want to see things going next. And I'll be there to guide you along the way, or one of our other amazing Boston IVF docs. I tend to talk a lot, so I'm going to continue to look at the chat here just in case somebody's telling me, hey, that's too much info. Okay, so the next question that came in was, before IVF is determined as the only solution, are there other treatments to help conceive? And absolutely, depending on your individual family building goals and circumstances, there may be many other options. There may be a few other options. We do look at factors that can affect attempts at family building and try to help you the most. This could be identifying lifestyle changes, could be identifying a surgical course or a further evaluation that's necessary. Sometimes there's different things that are identified that would help you achieve your goals without IVF. Some common treatment options also include ovulation medications. These are agents such as clomiphene and letrozole, medicines that help ovulation occur if ovulation is a concern for somebody. Some people come in and don't ovulate on their own. Some individuals come in with ovaries and ovulate every month, but have not achieved success despite being partnered and having sperm available every month. And then we're using medications to super ovulate. This may be in combination with something like timing of intercourse, if that's applicable, or intrauterine inseminations with either partner sperm or donor sperm. That's assuming that we're talking about pregnancy with ovaries. With IVF, there are other options as well. Oh, I'm sorry, so sorry to repeat myself. The next question is, after how many failed IUI cycles do you recommend a patient move on to IVF? So also very individualized, and assuming a relationship with egg and sperm that are coupled, I would generally recommend talking about next steps if intrauterine inseminations have not been successful after around 3 cycles. There may be a small benefit to a 4th. It depends on individual circumstances. We do see that there may be some opportunity for a 4th IUI cycle in folks that are coming in using donor sperm as well. So it's generally after 3 to 4 cycles. And after 3, I think it's a really nice idea to meet and reconvene and talk about any concerns, review cycles. I try to give folks an option I see somebody raising their hand, and I'm sorry, I'm not sure if I can actually answer the hand raise. So I'm so sorry that I can't do that. Definitely have the opportunity to meet after every cycle if that's what's going to work for you and answer questions, or if things are going well, where you feel okay on medications or the regimen that you're choosing for the family building, but things have not quite come to fruition, then we would be meeting after a few months. I try to give individuals an opportunity to have a plan for 1 versus 3 or anything in between. That feels right. I did have a next question that was, if I have a menstrual cycle every month, or is it possible to get a menstrual cycle every month and not ovulate? It's a great question. About 4% of cycles with chronic and ovulation, meaning that don't ovulate, will be regular, meaning cyclic. So you could have bleeding that is happening, but not related to the release of an egg. Most menstrual cycles are related to the production of an egg and the release of an egg and the hormones that are governing both parts of that cycle. And this is a conversation I don't infrequently have, but when we talk about fertility care and fertility treatments, I think it's important as an educator to try to help understand what all the terms mean. And during a normal menstrual cycle, The first hormone that your ovary sees in its most basic term would be FSH, it's follicle stimulating hormone. That's going to travel from your pituitary gland, which is located here. Some people have seen me do this at the nose level, and it makes hormones. Those hormones are secreted. They travel through the bloodstream to the ovary or ovaries, depending what the anatomy is, and follicles develop. Follicles are the spaces where the eggs are resting and waiting. And individuals are born with follicles within ovaries. Unfortunately, we use these throughout time. And it's actually kind of sad to think about. You may be very young and very healthy, but ovaries start to change pretty early on. So we had the most follicles that an individual has the most follicles they'll have when they're actually in utero prior to birth. And then life events happen and age occurs. Around 32, we start to see some changes more dramatically around 35, which is where I get a lot of questions about, what age should I be starting? And we can certainly talk about that. But the FSH hormone will make follicles grow and develop. An egg will generally become large and stops the other follicles from developing. So there's a cohort that develops, but one becomes dominant. It's kind of like starting the marathon. We see a bunch of great runners. One takes the lead. Unfortunately, with follicles, the eggs just stop growing except for one, and they are not used again. That one is ovulated because the estrogen gets high. Your pituitary gland sees that high estrogen, and LH is secreted. That's luteinizing hormone. You then ovulate an egg. The egg produces progesterone, and hopefully, if there is an opportunity for egg and sperm to come together, and that's the plan, either that happens in the fallopian tube and an embryo starts to grow and develop and end up in the uterus, or if that's not the case, a menstrual cycle happens. Occasionally, the signals, the estrogen from the developing egg and the progesterone from the cells that are left over from that ovulation, aren't in synchrony with one another, and bleeding just happens. And that can happen commonly with something called polycystic ovarian syndrome, which is what the signals are a little bit off, or it could just be that the timing of your cycles are regular, but that ovulation isn't occurring. It's pretty rare. It is pretty rare. Most of the time with a normal menstrual cycle, we can say ovulation is reliably happening. And I think I'm going to start to answer. Oh, please forgive me. Do you work with trans families and gender non-conforming gestational parents? Are providers at Boston IVF trained with things like pronouns, gender identity issues, etc.? My pronouns are she and her. And yes, thank you for asking. Absolutely 100% providers, staff, RNs, embryologists. Everyone is trained, and we are hopeful to provide a very inclusive and affirming environment to everybody looking for family building, fertility preservation, or whatever it may look like for you as an individual. You're unique and special. All right, now I'm getting to the chat. And I have some questions. There are quite a few, so I will do my best to go through these. We may not be able to go through them, but I'll try to give some more abbreviated answers at this point. Dr. A. Hi, Charlotte. Thanks for calling me Dr. A. For luteal phase deficits, short luteal phase, do you treat with letrozole, Ovidril, and progesterone, or would you try just letrozole and trigger first due to trigger shots, luteal phase support properties? Okay, so I think I could take this in a couple of parts. The first, luteal phase. So this is the part of the menstrual cycle after ovulation happens. So after the egg is released, the cells that are left behind will make progesterone. And in response, we generally have a pretty fixed time frame from ovulation to menstrual period. That could be 2 weeks for a lot of individuals. It could be 11 to 12 days and be pretty normal and physiologic. However, if it is short, that definition has changed throughout the years. It's been as short as saying, hey, 8 days is abnormal, or Anything less than 10 days is a little bit on the short side. There are ways to provide extra progesterone support, and that can be in the form of progesterone tablets. Generally, those are placed vaginally. It can be in the form of Ovidril. Ovidril is HCG hormone. That is pregnancy hormone. Pregnancy hormone works very similarly to how LH works. That's the hormone that causes the egg to ovulate and is detected on the ovulation predictor strips, but lasts in the body longer. We can't just use LH in the shot format. It doesn't last long enough to cause the ovulation, but HCG does. And Ovidril or HCG can help support the cells of the corpus luteum that create the progesterone. So that is a second way to enhance progesterone support during the luteal phase of the menstrual cycle. Letrozole, which is a medication that will help one ovulate either one egg if there's no ovulation to begin with, or multiple eggs if there already is ovulation and the goal is super ovulation. This also helps produce progesterone in and of itself, provided ovulation happens, because there may be more than one follicle that develops in response to letrozole. So the more follicles that develop, the more likely there are to be multiple corpus lutea, which are the cells that make progesterone. So any of these options could produce more progesterone during the luteal phase. Difficult to say exactly what would be the first choice. I would individualize it, Charlotte, but definitely talk to your doc about all the options that you bring up here. And second part to the question, short cycle, 26 days, does test 5 days before men's period apply, or is this inaccurate? So an HCG test is probably a really challenging thing for individuals that are trying to conceive, because there's always an anticipation when we take a test that there's going to be, hopefully a positive result. That's the goal. Potentially not. I generally recommend that we wait until there's that standard luteal phase before testing, just to decrease the probability of a false negative, meaning that it's a little bit on the earlier side. But generally, the timing goes from the time that you ovulated to determine when there's a possibility of pregnancy. So hopefully I answered that one okay. Charlotte, I wish you the best. I have the next question from Willa. Willa, how many months before IVF should an IUD be taken out? Great. So Willa, an IUD will be pretty good contraception method. So if you are considering IVF for reasons other than infertility, then the IUD can come out a month or two before IVF. And by this, I mean, if you're considering IVF for things like genetic screening of embryos, if there's a genetic condition, or fertility preservation, you can actually keep the IUD in place. If there's an IUD in place, we wouldn't know if there's infertility unless there's been attempts for a certain duration of time. Now, that would be a year in under 35 if there's exposure to sperm during that time, or 6 months if you're over 35, if there's also exposure to sperm during that time. IVF could also be performed for a variety of other reasons, in which case that IUD can stay in for as long as you want the contraception. Fortunately, we also have some new definitions for infertility that the American Society of Reproductive Medicine just released last week at our annual meeting in New Orleans. So some of those may apply as well. I believe Ashley is next. Is Boston IVF closed for monitoring retrievals and transfers during the winter holidays at all? Great question, Ashley. So some of our centers are not monitoring during the winter holidays. The Waltham Center is monitoring and performing procedures during the winter holidays. So in the local New England area, there is an opportunity to receive care every day of the year. Very accustomed to menstrual cycles and timing. Please explain more about PGT-A testing. This is from Anonymous. Hello, Anonymous. So PGT-A testing. This is testing an embryo for the overall chromosome complement. It is a process that happens after eggs are removed from the ovaries, fertilized with sperm, and allowed to grow in the culture dish for up to 5, 6, or even 7 days of development. At that point, there's a blastocyst embryo that we hope develops, well, hopefully more than one, but occasionally there is just one. And PGT-A testing can take cells away from the embryo to utilize them for pre-implantation genetic screening. So the cells of a blastocyst, there's about 100 to 200. We may remove 5 or 6 cells, for example, from that embryo, freeze the embryo, send those cells off to receive results on, and receive what I say is kind of like a report card 2 weeks later. And it will delineate the number of chromosomes that were seen within those cells, as well as sex chromosomes, so X's and Y's. It will give us information on those things. This is similar type of testing that's done during early pregnancy. If you're planning pregnancy, it can be done through self-fetal, your DNA test with your OB early on, or more invasive testing. That testing is still recommended even with the PGT-A screening, because the test results are not perfect or definitive. But this is something that is often employed by individuals. And does this test help with outcomes? It's a tough question. It depends on individual circumstances. If there are screened embryos that are what we expect to be normal, meaning euploid, which means the report told us that those cells that were screened had the correct chromosome complement, not a Down syndrome, not a trisomy, not a monosomy, then that embryo has a really high probability of implanting, and higher in comparison to one that did not have that testing. However, individuals that are of a young age are at lower risk for these things. Folks that are of an older age are a little bit higher risk. Individuals that have had pregnancy losses that are really challenging may also select to think about genetic screening, because it does give us a little bit more information on the embryo and tries to reduce the possibility that an abnormal embryo or an embryo with abnormal chromosomes is implanted back to the uterus. I hope that helps, anonymous attendee. Anonymous attendee next. I used to get pregnant so fast. Now that I found the Mr. Right, we can't get pregnant. I'm sorry for the tear emoji. That is difficult. We would be happy to see you in one of the offices. There's a lot of information that you can learn just by having a conversation that's individualized and personalized to you. And absolutely, if it's been difficult for you, the right thing to do is to talk some more. The next anonymous attendee, if I have done 3 IUIs with 3 to 4 mature follicles and no male factor, so unexplained infertility, is that safe to assume 9 to 12 eggs if I had done IVF would have also have failed? That's a difficult assumption to make. The way that I think about medicines and IUIs, things like letrozole or the clomiphene, which is the other one that we had not talked thoroughly about before, but medicines that help you ovulate more than 1 egg. And combining that with an intrauterine insemination, which is a very common fertility therapy, it's fairly basic. What we're doing is trying to help more eggs ovulate and then placing sperm that's been washed and concentrated into the uterus to try to get egg and sperm closer together. So it doesn't always rectify or treat an underlying concern about how egg and sperm fertilize. IVF can do that. IVF can help the fertilization process by either combining egg and sperm together in a dish or injecting a sperm into an egg, which is called the ICSI process. And then we see a little bit more about how embryos do outside the body. So once egg and sperm are combined, they're in a culture environment for 3-5 days, depending on the circumstance. Occasionally, we see that embryos don't do as well. And these are some reasons why we think unexplained infertility is the case. So I don't think that we can make that assumption. And it sounds like if you're ready to have a further conversation, it may be an appropriate time to do so with your provider. Kelly. Hi, Kelly. Can I discuss unexplained infertility? And great question to follow that up with. Thanks for asking. So unexplained infertility means that, well, it's also called idiopathic. We're not entirely sure why. There are some theories as to why there's unexplained infertility, some of which you just heard. But essentially, testing comes back fairly normal. So during a fertility evaluation, we will be looking at ovarian health, uterine health, making sure that fallopian tubes are patent. And if there's sperm, we're looking at sperm health, the count, the movement, the shape of the sperm. If all the testing comes back unremarkable within ranges that are expected for age and nothing has been identified, then that falls into this unexplained infertility diagnosis, which can sometimes be relieving to folks or be frustrating because there's not an answer. I hear it both ways. And with unexplained infertility, it may just be that there needs to be more opportunity, more eggs, more sperm, which is the process of ovulation induction and intrauterine insemination. Or it may be that egg and sperm really do need more help coming together and developing into embryos. So with unexplained infertility, it may be medicines such as ovulation induction with letrozole and clomid with an intrauterine insemination, or in vitro fertilization if there's nothing else that's been identified during the evaluation. I hope that helps, Kelly. Anonymous attending next. I was hoping to better understand why ICSI is recommended for cases of male infertility and when there is some number of normal sperm. Why can't traditional fertilization for IVF be used? There are two ways to fertilize eggs. The first we call by many different names: regular insemination, conventional insemination, microdrop insemination. Essentially what it means is that thousands of sperm surround eggs, and then it's up to sperm and egg to try to combine with one another. That's generally used when semen analysis parameters are within normal limits, because we do expect that the sperm that are shaped normally will probably be able to bind to egg, and egg will probably be able to bind to sperm, as long as there's enough that are moving in the right direction. Now, unfortunately, that doesn't always happen. So ICSI is commonly recommended. This is intracytoplasmic sperm injection, where an egg is very carefully placed in a dish. A sperm is selected by the embryologist, and under a large microscope, the sperm is injected into the egg. And this is to try to help overcome any difficulties that the sperm may have in doing that by themselves, or any difficulties the egg may have in receiving the sperm. It can go both ways. In follow-up to that question, the next is, I was hoping you could also discuss some of the long-term outcomes found with ICSI. Some of the long-term outcomes specific to ICSI that are different than that of IVF would be considerations with overall birth defects. Now, this is always a scary one to talk about because birth defects can be something pretty minor that don't manifest until later in life, or something significant that would be detected during monitoring for pregnancy. And IVF has been associated with slightly higher risks of birth defects than when compared to unassisted conceptions. And ICSI is a fraction higher than that. There's not a way to reduce those risks with ICSI that we are yet aware of. All right, I hope that helps. Willa, for selection purposes, genetic disease or gender, can I reject the embryo of the undesired genetic screening profile? You can select not to transfer an embryo of the undesired genetic screening profile. This would mean if there is an embryo that comes back that is found to be a carrier of a genetic disease, then that embryo would not be recommended for transfer. Or if you're looking at sex chromosomes of the embryo, the number of X's or the presence of a Y, then that could be used for selection purposes and embryo transfer. I hope that helps. Charlotte is asking, does exercising moderate intense during the 2-week wait, I like the abbreviation of 2WW, really harm affect implantation? Charlotte, thanks for asking about exercise. Exercise is such a great source for so many of us for stress reduction. And this 2-week wait can be really stressful. So it's hard to think about eliminating a part of ourselves that help with stress and just feel good. If you like to exercise, then it just may feel good. So I would say that more intense exercise wouldn't be recommended. I can't tell you with definitive information that it will harm or affect implantation, but it seems to make some logical sense that moderating the amount of exercise could be beneficial. And I do not know for sure. I do not have a study for you that I can quote and look at and tell you that exercise has made a big difference. I would say that I would use precautions that you would use during early pregnancy, meaning staying extraordinarily well hydrated, avoiding excessive heat, things like heated yoga classes, spin classes. Really more moderate would be recommended over vigorous, and activities that will not produce trauma to the abdomen would be recommended as well. These are things that we may enjoy in New England, like downhill skiing. I generally ask that folks avoid, which can be hard when it's snowy and cold, and one of the enjoyable sports that are possible. I don't have a great answer for you. I don't know. I would just take really good care of yourself. If your ovaries are still large, that can definitely be harmful. If you have gone through in vitro fertilization, or you're using ovulation induction medications that are producing multiple follicles, the ovary gets bigger. Normally our ovaries are small, but with follicular development, they get big, and they can be really, really large. And vigorous activity or anything that's really jostling the pelvis puts that ovary or ovaries at risk for torsion, which is a surgical emergency. So I would definitely be cautious. Long-winded answer, my apologies, but hopefully that's helpful. Hi, Melissa. Good evening to you as well. What are your thoughts on a 3CB embryo? Every embryo is graded a little differently in different embryology labs. So I don't think that I'd adequately be able to answer your question. It would depend on individual circumstances as well. Has this embryo been screened genetically? Is it considered a high quality embryo in the laboratory that you're working with? Parameters are employed differently at different places. And, are there other embryos that are available to you or not? I don't have a great question or a great answer for you, Melissa. I would definitely talk to your provider. Anonymous attendee, are there other causes of PCOS or polycystic ovaries besides insulin resistance? This has been my diagnosis by ultrasound, but prolactin, insulin, and A1C are normal. Thank you. PCOS is generally diagnosed well, there are a few different ways to diagnose PCOS. It's not standardized, but ultrasound alone would not be enough to diagnose polycystic ovarian syndrome. It may look like there's polycystic ovarian morphology, so the ovaries look a certain way in ultrasound, but generally that does need to be associated with hyperandrogenism, which is either evidence in the bloodstream that there's elevated testosterone or some of the other androgens, or clinical hyperandrogenism, hair growth, thick, dark hairs that are growing on places that you'd prefer them not to be, or scalp hair loss, acne. So generally, there's a couple of criteria that are used, and importantly, abnormal menstrual cycles. So if those are present, then that is something that would be of concern. But yes, there are other ways to diagnose PCOS. And hopefully you're welcome. Anonymous attendee next. Hi, can I speak to ovulation with lower LH and PCOS? Is it still possible to ovulate with an LH of 0.11? PCOS is often associated with abnormal production, elevated production of LH. There are other explanations for a low LH. And unfortunately, without knowing exactly what the units are to this LH level, I'm not sure I can answer your question appropriately. But there would be an importance to making sure that there's not an overlap with something like hypothalamic amenorrhea, which means that the pituitary gland is not making enough of that LH hormone or not making enough FSH hormone. That can happen for a variety of reasons. It can be idiopathic or unexplained. It can be secondary to excessive stress, exercise, difficulties with proper nutrition, weight reduction. That would be something to explore and consider, depending on your individual risk factors. The next question I have: what happens once you go through the entire process and get pregnant? Does Boston IVF deliver the child? Boston IVF does not perform delivery of kiddos. It would be awesome and amazing to do a delivery again. It's been a number of years since I have now, but generally your OBGYN will be seeing you after the first ultrasound to make sure that everything looks okay and take you through the process of having a healthy child. Joanna has a question next. I took Clomid and have a low AMH. I had 2 eggs mature, but neither fertilized. is this expected with a low AMH to have 2 eggs on the first cycle? It depends on the level, Joanna. So 2 eggs may be giving you a good opportunity. There's a lot there that could be personalized a bit more for you in regards to age and diagnosis. For example, if somebody is young and they are not ovulating, 2 eggs developing or 2 follicles developing an ultrasound gives a really good opportunity. And, the goal with something like polycystic ovarian syndrome is generally monofollicular development, meaning 1 follicle to grow. And an older individual that has a low AMH, 2 follicles still is more opportunity than 1, but perhaps there are other things that your physician would be talking to you about, just depending on risks. The goal is 1 healthy pregnancy at a time. So minimizing the risk of twins and triplets is certainly something that we strive to do as well. So it will be a balance. Let's see, Matilda, what to expect with IVF? I hope I pronounced that correctly. Please forgive me if I did not. Treatment, appointments, side effects, duration, insurance, out-of-pocket expenses, approximately. All right, so what to expect with IVF? I love IVF. Not that I love that everybody needs to go through IVF if they need to go through IVF, but I'm very passionate about it. With in vitro fertilization, I try to break down the process into larger components. So approximately 10 to 12 days of hormone injections, an egg retrieval that occurs 2 days after the last injection. An egg retrieval is performed under anesthesia in most centers. Vaginal ultrasound with a small needle that's attached, which is why the anesthesia is helpful. The needle enters into each follicle that's large enough and safe enough to enter into during the process, and the fluid is pulled back. There's a little bit of negative pressure that's exerted, so we're hopeful at the point in which the egg retrieval is happening that egg is floating around in that follicular fluid and can just come back into that. This is where the term test tube comes from, into the little tube. It's just a collection device where we're collecting the egg. The embryologist will be looking at the egg, and then fertilization will happen with either the ICSI or the regular conventional way. And approximately 5 days later, there's an embryo transfer. An embryo transfer is not a painful process. This is the process where if you're receiving the embryo yourself, you come in, and it's a procedure that places a small catheter into the uterus under ultrasound guidance. So often you'd be asked to have a full bladder so that an ultrasonographer can see well over and into the uterus. And then a small little catheter will place an embryo into the thick part of the endometrial lining. There are side effects. There are side effects to IVF, which include overstimulating the ovaries. That's called ovarian hyperstimulation syndrome. You are monitored very closely in order to help prevent ovarian hyperstimulation syndrome. And that's done in a number of different ways. There's opportunities for infection. Unfortunately, when you use injections, that's pretty rare. The egg retrieval, most of the time, is uncomplicated. There are complications that can happen from any surgical procedure. So there are consent forms that delineate some of these risks in more detail. They do include infection or bleeding or damage to things that are around your ovaries, including your ovaries. That is a very rare thing to have happen. And unfortunately, sometimes mature eggs are not retrieved, or eggs can't be fertilized, or there are no eggs. Again, that is rare. And then as time goes on, we hope that embryos do well in the culture environment. Our culture systems are doing really, really well, such that most of the time we do have embryos, but occasionally there's no embryo development and no opportunity for pregnancy. Let's see, insurance, really dependent on where you're at and who your insurance is through. Fortunately, many of the New England states have good insurance coverage, which means you may not have a significant or any out-of-pocket expense, but that is extraordinarily dependent on the policy. We do have fantastic financial advisors that help you understand that in more detail. So I guess that's a brief overview. All right, Courtney, for women who don't ovulate, but hormones look normal, only thing high was prolactin, but barely elevated. FSH is a 6. What other cause would make someone not ovulate, bleed irregularly, or barely at all? All right, Courtney, thank you for the question. So an elevated prolactin level can certainly cause some ovulation dysfunction or difficulty in ovulating and irregular bleeding. Generally, light bleeding, as you describe, is associated. So it sounds as though you've had an evaluation for prolactin, which is good news. Most of the time, if one prolactin level comes back elevated, it would be repeated with some precautions, fasting, not having a heavy meal beforehand, no exercise, and then that may be treated with treatment. It is possible that your body will start to ovulate and have more regular menstrual cycles. Some people need a further evaluation than that, and depending on your provider, they may discuss that with you or refer you to a specialist that works on the pituitary gland. Okay, Aspen, are there new technologies in recent years which can help older women have their own babies? So, Aspen, it depends on what age we're discussing, but I think IVF, donor oocyte are two very good options for individuals depending on characteristics, age, ovarian reserve, your goals. Donor eggs have changed a little bit more in recent years, depending on what this is relative to. But we have egg banks that are readily available. These are banks where individuals have donated eggs, they're cryopreserved, and then a cohort of eggs are purchased, fertilized with sperm, and then embryos are created. And that is in contrast to years ago when an individual's option for donor eggs was selecting an agency or a person that they would know to go through the process of in vitro fertilization, the stimulation shots, the retrieval, and then collecting eggs that way. Hopefully that is information that is useful for you, Aspen. Roma, thoughts on Luteal suppression if a biopsy was done for small polyp, but you don't yet meet criteria for recurrent implantation failure? Have a successful transfer prior to this biopsy. Hysteroscopy shows some mild evidence of adenomyosis, slightly thickened uterus, and some hypervascularity. Overall seems mild. Roma, I think I can answer part of this. Adenomyosis can be a challenge during a fertility process. And if there's focal adenomyosis, there are some reproductive surgeons that will address that with surgery. Otherwise, Luteal suppression is one opportunity. So I think that's a possible option depending on what type of therapies you're considering, and if you are undergoing therapy. Yes. Kristen, is chronic endometritis something that once taken care of with antibiotics can naturally recur? Yeah, unfortunately, it can. Chronic endometritis, it can recur. It's more common with procedures or pregnancy losses. The next part of your question is, should it stay away? Hopefully it does. Yes, hopefully it does. Afraid to try again after successful treatment for chronic endometritis 2 years ago after 2 losses. If you have not yet seen a provider and it's been a couple of years, I would recommend that for you, Kristen. I can understand how you express that you're afraid to try again. Generally, antibiotics do help with endometritis. There could be a rare case in which repeated courses are necessary, but further details I wouldn't have for you tonight. I had an egg retrieval, so I'm sorry, anonymous. I had an egg retrieval, but embryos developed poorly. How do I know if it's an egg issue? Can they tell by looking at the eggs? Unfortunately, embryos can develop poorly for a number of different reasons, and it's pretty difficult to define. It can be egg, it can be sperm. It depends on how preliminary testing looked, what risk factors there are, ages. And most of the time, we'll think about who's at higher risk, meaning, unfortunately, age of the egg is generally the issue why embryos don't develop as well, but that's not always the case. By looking at the eggs, we're not always able to tell. The embryologists very diligently look at eggs, and occasionally they may have a comment to make, but no, there's not. There's not one thing. I'm considering egg freezing. Could you talk a little bit about how invasive the procedure is versus IVF? If used later, absolutely I can. Anonymous, thank you for asking about egg freezing. Egg freezing is a fertility preservation process. This isn't something that we've gone over yet tonight, and I absolutely can talk to you about it. So up until the end of 2012, beginning of 2013, egg freezing was considered experimental and was being performed in places, but with special approval. After that point, the American Society of Reproductive Medicine said, hey, let's recognize this as a way for folks to preserve fertility with medical or without medical indications. The process of egg freezing is very similar to the in vitro fertilization process, but just without the fertilization. So it's the ovarian hyperstimulation and the egg retrieval, but then eggs are frozen very quickly after the egg retrieval that very same day, and could be used for you in the future if you ultimately decide that you want to use cryopreserved eggs. So you would be undergoing injections of hormones after an initial evaluation. The injections of hormones, again, in general, let's just say just under a couple of weeks. The egg retrieval is 2 days after that. And then you know that information about how many eggs are cryopreserved. We generally will freeze mature eggs. Those are eggs that can eventually receive sperm in the future. There are also opportunities to freeze eggs that are not at the mature stage, but that would require a little bit more discussion with your provider. Eventually, people may come back to use frozen eggs if pregnancy has been difficult, or let's say age has advanced and ovaries aren't healthy any longer. Or individuals may become partnered if that's not currently the case with somebody with sperm, and become pregnant very easily, and then consider using cryopreserved eggs in the future if the next pregnancy is years after, or a third pregnancy. So hopefully that's helpful to hear. But yes, egg freezing is becoming a more and more common occurrence and something that can be very helpful for future family building. And it may not be necessary at all. It is important to emphasize it's not a guarantee either. It is possible that there are cryopreserved embryos that just don't thaw or develop into healthy embryos, but that would be part of the detailed conversation that you would have with a provider. And I'm realizing that we're getting very close to time. Let's see if I can go over a couple more, because you have all been so kind to join me tonight. Anonymous asks, can you go over the genetic testing component and timeline of IVF? We may have addressed this a little bit, but in brief, the timeline takes a couple of weeks of injections, an egg retrieval, and then culturing embryos in the embryology environment. There may be a pre-treatment component that we did not talk much about this evening, but this is where somebody may start birth control pills to help synchronize the follicular cohort such that the eggs will try to develop and the follicles will try to respond all at the same time, or estrogen patches are used in that regard as well. There are a few different options there. So overall, that can take a little bit longer. And now I'll go on to the next question. Matilde asks, what is considered high FSH? What are the symptoms and impact of infertility, and what treatment would you recommend? FSH is generally drawn on the third day of a menstrual cycle, because this is when we can best interpret the results, and we know where the estrogen may be in response to an FSH that is developing. So considering FSH levels, high is generally over 10. Symptoms may or may not be there. If FSH is extremely elevated, there may be menopausal type symptoms. That would be, hot flashes, vaginal dryness. What treatment would I recommend? It would depend on many different things. With high FSH, we have to consider whether further administering FSH through injections, such as the injections that are used during IVF, could be beneficial or not. So that would be a very personalized conversation. We are at 8 o'clock, and I'm going to see if there are any of the next questions that I can answer in just a moment. And I'm really grateful to all of you for being here tonight. I'm so sorry that I was not able to get through all of these, or even a fraction of them. I can answer one more from Anonymous. What does the timeline look like after egg retrieval for frozen transfer? If you are doing a PGT-A cycle. So generally it takes PGT-A results a couple of weeks to come back. And depending on where you fall with your menstrual period, it's probably a good month later. So by the time you have an IVF cycle, you then have a bleed, and that bleed is before the results are generally obtained from the PGT-A test. And then there are ways to go right into a cycle if you're feeling very well, meaning your ovaries have, no longer hyperstimulated and you're feeling okay. But it is also very reasonable to wait for the next period and then prepare the uterus for an embryo transfer, which happens a number of different ways. A frozen embryo transfer can occur during the natural cycle by monitoring your own natural menstrual period, by supplementing with estrogens and progesterones, or by using medications to help you ovulate, and then timing a transfer appropriately. So a very quick answer to a great question. So I think with that, what I'll have to do is, again, thank you. And I wish all of you health, peace, and ease, and all of the success in your family building that you desire. Thank you for being with me. I'm very grateful.